our locality was many uneducated. I speak to Professor Muhammad before about the early time for doing the testing. And I found the only way for non-educated person not to tell him, you may need this, you will not back again. For me, I worked at this with these patients in several years, more than 20 years. The only way for non-educated person to inform him, this fistula will improve your kidney function. And I'm sure he can do it in the same day or the next day. This is from my experience, not written. Okay? I know there's some sort of time, but I will try to focus on the strategy and the general rules to know more details about the surgical details, no surgeon here for no need for more detail about the surgery, but about the protocol and how we choose the arterial patient needing and access. Strategy and maintaining the hemodialysis access is the cornerstone for long-term renal replacement therapy. The hemodialysis technique has been improved sufficient to allow many patients to survive for as long as the dialysis access can be maintained. The chronic access to the circulation finally became a reality in 1960 when the Scrabble introduced the Teflon silastic arteriovenous fistula shunt, which brought a new hope to the patient with the end-stage renal failure. Many disadvantages of the Scrabble shunt were overcome by the introduction of the subcutaneous arteriovenous fistula by the Precious Mino in 1966. Despite creating the end-site arteriovenous fistula at the wrist. Subsequent development of the bridge fistula initiated with the saphenous fistula like reverse saphenous graft, and later on with the synthetic material further expand the availability of hemodialysis to a larger population. The introduction of the Prof Ehab for the bridge fistula in 1976 was another milestone in the dialysis access surgery. Since its introduction, it has become the most popular graft for creating bridge fistula. For the initial evaluation of the patient coming for me to join the arteriovenous fistula is very important, because we must evaluate everything for them to do the proper decision. So the initial evaluation should not when the patient is seen in the nephrologist office early in the course of the disease, as we discussed this point before, and not a few weeks before starting the hemodialysis. It is highly advantageous not only to consider the first procedure, but also to have a long-term plan in your mind during initial evaluation to allow for a stepwise multiple access procedure. So this is an important point. Not looking for the best and the easy fistula for the surgeon, but for the safety and the long term for the patient. This is the most important decision for the younger surgeon doing with this access. After initial evaluation of the clinical mapping of the vein, I specified for the availability of the vein on the forearm and the arm under little vector cave. We're looking for this availability of the vein. We need almost sometimes some motivation or sometimes not available to evaluate the proper of the vein after multiple punctures. As a routine nowadays, you can use the duplex scan for evaluation the superficial vein, especially in the arm, so it can help you to give a maximum chance for the patient to using the autogenous material and using the fistula before we bring or bridge to go into the synthetic material. So I think there is a talk for Professor Tariq here today or tomorrow about the radiologist aspect for the arteriovenous fistula, so more details about the value of the duplex scan, the diameter of the vein, the diameter of the artery, and the flow of the artery, which can help a good decision. And I think the new data at this point helps so much to give the vascular surgeon or anyone dealing with this for the proper site and the proper access can be done. from the venous examination or the arterial examination. And also with the problem of the central venous cluster, if there is no for religious catheterization, especially the wrong placed subclavian cluster with the possibility of central venous stenosis, it can be evaluated not only by the duplex, because false result is so much, but almost always we use some of the recent modality from the CT scan or MR of the situation. After this evaluation, we're going to the selection of the axis. And this point is very rapid. We should consider this general guidelines before axis placement. We select the arm basis rather than the leg, so the priority for the arm rather than the leg. Select the non-dominant arm before the dominant arm. Select the whole arm before the arm for the axis. Avoid, as you can, as possible, the atherosclerotic segment of the artery by your palpation or by the data available for you from the duplex scan. Avoid the vessels which cannot be ligated. It's better, so we prefer the distal fistula rather than the proximal fistula. If a problem like infection or something like that, there is no problem, so much trouble for the patient. The selected vein should have a long segment to allow the variation in the functional side. Not only looking for that visualized short segment, I can do fistula over here. We are not doing the fistula, but almost always I say I'm doing axis. So not only something like I have a syringe, so go ahead, go to the nephrologist, you have a syringe with you, go dialysis, and he cannot find a long segment enough for him to do a dialysis. The side should allow for easy access and easy combination with the patient arm in a comfortable neutral position. This is very essential in choosing the proper access for the patient. So the wrist fistula is the first choice. If it is available, go to cephalic vein, whatever in the dominant side or the non-dominant side, this is the first choice for any patient to unlock. Because it's simple to create. If the blood pressure is good, non-hypertensive, it can give him long-term latency and the side for communication. And at the same time, it preserves more proximal vessels for more further access. So if I found a wrist fistula, a good vein, and the more good vein in the proximal, and it would be easy for the vascular surgeon to do the fistula in the arm rather than the distal. It takes longer time for him. It's better for the patient to do distal first, and then if he needs later on after surgery, the proximal can do first. This is an example of the endoside arterial fistula. The second choice after the forearm, we're looking almost for the brachiocephalic epifistula. It is also give for the patient high blood flow compared to the rest, especially on borderline blood pressure, and it's very great in the other arm. It's easy to cannulate, except in obese patients. Sometimes nowadays we see in obese arm you need to do structuralization even to the spheric vein. As an example of endoside, proximal cephalic vein to the end of the side of the arm. If the rest of or the endofistula cannot be created, a dialysis arterial graft using stent graft material, or the other alternative, looking for more autogenous material before we shift to the stent graft material. And this is the rationale also in our locality or in Egypt to refer to do high insult infection with the stent graft, looking for the basilic vein and to transport basilic vein. And almost all of the situation, you can assess if it's clinical or using the duplex, you can inform you that you have a good diameter of the basilic vein until to the axilla, so you can do this form of the fistula. After full incision, you can open the fascia and remove the transport with this basilic vein and put it subcutaneous and put it in the two sides, so you can have a very large long segment of the basilic vein with good quality. You can get excellent long-term result for that later on. And I think this is after anastomosis. So this is two incision. We will refer to incision now instead of long incision. And putting the vein, this is after the anastomosis. You see the vein is seen more than one. Sometimes in some patients with the borderline diameter of the basilic vein or clinical or the duplex, we do it as two-stage. We do the first stage under local anesthesia for the fistula, and after 2 to 3 weeks we can do him hospitalization to get under the graft to be ready for the dialysis. So this is assessment according to the diameter of the vein and the situation for the patient. When the constructing artificial venous fistula is no longer applicable, the use of the synthetic graft as a best alternative. And this is one of the advantages of the fistula. You have the synthetic graft, large surface area available. For me, it is technically easier than the artificial, but for the patient, not short long gap for the insertion to maturation. For the adrenal fistula, it needs at least 4 to 6 weeks to be mature, to be ready for the function. The cystic graft, you need only 12 days. Okay? This is for the standard BDFA. Nowadays, I speak about the new modalities available with the new technology that's available now, new material of the BDFA, which can be used in the same day or even in the second day. It doesn't need very graft healing to be used, so you can use what is more for the price of the graft, but this is one of the recent modalities during attending the vascular access conference and sharing across previous years. This is available in the Euro now, the synthetic material, which can be used not waiting for 2 weeks. So this is a good option not to use the customer, and they can use this new synthetic material for patient presented with late and needing dialysis early, not waiting more for a long time. You can use this material for use. But the cystic graft can help to both different configurations, different size, you can both for dialysis. And this is a classic for the specific material, and this is the classic size, which we perform in the arm. Sometimes we also move in the forearm according to the availability. But I think the forearm we need a good softness, a good basilic to be available. If a patient comes with me with has good basilic, I will do it for him transposition rather than synthetic. So I work on synthetic when there is no way to use an autogenous material, and the different configuration and different material. And also another recent technique in the previous years was the using of the hybrid OR. So with this technique available, this is the hybrid OR, hopefully to be available in Mansoura, and the recent center in the cardiovascular system soon after several years to be available in this room, helping the vascular and also will help the access. And by this type of technique, you can use the problem of the cystic graft is the intimal hyperplasia and the stenosis near the venous side. They introduce a new graft which you can both just by puncture in the artery, so it is sutureless anastomosis with stopping, no turbulence, no sutures, so the less dense hyperplasia, and put the graft under cutaneous and put just by local anesthesia the arterial anastomosis. The starting, and I think there is presentation about this type of the graft in the previous years in the sharing across using the OptiFlow anastomotic connector. This is one of the most recent modalities for using the bridge material for arteriovenous fistula. The problem if I don't have a direct access, whatever by the autogenous or by the synthetic material, sometimes we can look for another unusual access. There is a long series of the unusual access available. We don't use this unusual access except we all these trials before in the primary access. And in our units here, the incidence of the unusual access in relation to the usual access of the vascular surgery in this hospital is about maximum 5% of the case. But all the cases going to the primary access. This is in a rapid manner the different type of unusual access, because more and more details for everyone will take a long time, but this is directly concomitant arteriovenous fistula. This is if by the duplicate scan and the proper duplicate scan give you data, there is no superficial vein, there is no basilic, no cephalic, postart, and but to have a good vein concomitant diameter 4 mm or 5 mm, so you can break you vein concomitant arteriovenous fistula at 1 stage or 2 stage, but the problem it needs very long time for maturation. It can reach up to 2 months. So for me and for the patient, it is very frustrating. But it's one of the alternatives if you are confronted and want to use an autogenous material and go away from the cystic material. Another one also technique which is also used for many patients here to avoid the cystic material, especially the rural area. If I found the golden softness in the leg, I can leave it in the leg instead of transposition in the arm and do the saphenofemoral arteriovenous fistula by different configurations. But if the diameter 4 or 5 centimeters, you can do looping in the leg. It is very suitable for sick patients, very suitable for the men more than women. So it also helps sector and not all the patient but to get excellent results also for many patients up to 2 to 3 years. This is another configuration. If it is not available for any autogenous material and you need also unusual access, we're looking for an axillary fistula. The old fashioned, not done nowadays, and it's not between the axillary artery and one side, and I know Professor Carter, this is one of the history. We don't use this technique nowadays, but we use the other modification. We use only one side of the axilla to expose the axillary artery and the axillary vein and do looping in the arm and the third part of the axillary vein. This is also a special group. I think it is will be available in the literature later on about our experience in the ipsilateral axillary fistula using the synthetic graft for the hemodialysis access. Another sometime in the old history, also there is no available in the arm, or the patient like giving the arm due to a infection. It's the only one case which we do femoral. Later on, almost shifted. If I'm confronted, you must do synthetic graft in the lower limb. You only use the superficial femoral vein and superficial artery at one side and keep the other side for another axis. So you can use the same situation, but in the one side instead of two sides with less instant infection. If after all of this, and there is no available deep veins to drain the fistula, so you cannot do even to whatever primary fistula or unusual arteriovenous fistula, because there is no available deep veins to drain this arteriovenous fistula. So the only alternative for this patient with good blood pressure and hypotension is to use arterial prosthetic loop. This is the last resort of dialysis if the patient has multiple failure of the arteriovenous fistula and no available for him or contraindication for the protein dialysis. I can shift to arterial guided that the patient is making dialysis in a special center, knowing how to avoid the giving medication through this access to avoid the complication of the intra-arterial injection. But I think it is solved a problem for many patients in our locality, especially they start in dialysis late with multiple central venous obstruction, whatever in the arm or in the lower limb, and you can do any fistula for him. But I think this is a good alternative. And the basic for the arterial prosthetic loop compared to the arteriovenous graft, that the deep vein is not essential, the distal perfusion is not decreased. So if the patient has some sort of vasculitis or decreased perfusion in the arm and the hand, you are not concerned about this point. And the third one is for the cardiac patient, and you are concerned about the volume overload for the cardiac patient with the fistula. So the arterial prosthetic loop will not give overload for this patient. So I think it can serve also this patient. An example of the first case, and since it's done here in this center for this poor patient with multiple carrier and multiple even transplant failure, and we did for him through the supposal of the arterial, and this is the picture for him. We'll start in the dialysis 2 weeks after that, because there's no any available place or site and multiple failure even of peritoneal dialysis. And the picture of the CT angio for this graft post-op. In conclusion, we should consider the general guideline for the access placement. Okay? Tracheoarteriovenous fistula and autogenous saphenofemoral fistula is a good alternative access which can be explored the maximum utilization of autogenous vein before shifting to the synthetic bridge fistula. Arterial group is reserved only for patients without any other promising possibility for creation of more conventional vascular access. This approach is unusual but very efficient and attractive alternative as a vascular access for the hemodialysis. The indication for unusual procedure must be individualized and judged between the benefit and the risk for the patient. Thank you very much.
Thank you, Professor Ehab, for this presentation. I think
I will reserve the minute time for you.
Thank you.
شكرا. طبعا دكتور إيهاب على انه عميد لكن is an outstanding professor. So he is very busy. So after this talk, we cannot even call him over the phone. So I take this opportunity to ask you an important question. All of us as nephrologists are confronted with a fistula or grafts, functioning fistula or graft that become closed. And we are in a puzzle whether to refer it for salvage or not. So as a surgeon, in a practical way, what are the salvageable fistulae or grafts for you? When should I refer a closed fistula or graft to you? And whether there is an importance for time or not?
Yes. Thank you, Mr. Ahmed, for this excellent question. But this is an important point because we divide the patient into autonomous or synthetic. One of the advantages of synthetic is the patient develops closure. At any time you can give him the style of thrombectomy, whatever surgical or biochemical thrombectomy under local anesthesia for liquid therapy. And this is the evaluation almost always in this case in case of synthetic. I don't have a rush of time and not necessary to do thrombectomy in the same day, but can be arranged for the second day and so on. And in this situation, you must evaluate the patient and the cause of the closure. If the patient working under dialysis with this graft in your place for several times and there is no stenosis, you feel there is no high pressure at the venous side, the good flow of the inflow of the so there is no technical problem or mechanical problems through several years. Also through several months, but after 1.5 years starting to develop sudden closure without hypertension during the dialysis, without hypertensive attack in the home. So mostly as this situation, the closure will be at the venous side and the hyperplasia. Not only with thrombectomy will solve the problem, but not to be compression angiogram during your work to looking for the cause of the closure so you can maintain the graft. If you don't have these facilities and you can travel to dilate this segment to percutaneous or endovascular technique, because it is, if you're dealing with this problem, you need a lot of money and a lot of expenses dealing with the occlusion. You need percutaneous caster, you need PTA, you need sometimes the stent. So a lot of not just a property caster to put and remove the clots and so on. This is only helpful for some patients. I expect from the head of the patient, everything is going okay with me, with the follow-up public scan, with the follow-up clinic, the patient don't worry, but he developed sudden attack of hypertension before the dialysis or during the dialysis, and developed this closure last immediately after dialysis. So I expect this patient will get benefit from the early interference, whatever in the same day or the second day, and take benefit from the thrombectomy, and they will not taking a lot of more details or more procedure which help to maintain this access. The problem with the autogenous fistula, right? Autogenous fistula, if the patient coming for me after several days with thrombosis and the vein is starting to be inflamed or rest and tender, there is no way to look for him, right? And the evaluation in this case, the patient coming to me with this closure is coming early and there is no thrombosis. Sometimes the vein is occluded just as the inflow, and the other vein by clinical palpation it is collapsible, there is no inflammation and so on. So the patient can return for early interference because the occlusion just as the early. But with evaluation of other patients with this fistula and the multiple stenosis and the multiple dilatation and the multiple aneurysmal dilatation, so So this patient will not take any benefit from thrombectomy because there is multiple occlusion, multiple stenosis. So you cannot deal with this. In this situation, I prefer not to interfere with the patient. But if the patient has a very good vein without stenosis clinical or an rehabilitation and with his history, he develops sudden closure and hypertension, everything is okay previous years or several months, so this patient can take the chance of the benefit of local or surgical thrombectomy. So no strong decision for the all, but every patient must be evaluated from the hypertension side, from the data available for him on this, and the data available from the evaluation of the original graft. It is, can I do effort helpful or not? If I take empirical, go ahead to the theater, put the customer. If it is bad, will good. If it is not, go away, put the customer and look for another else. But this is the simple statement which can I give you simply, so you can decide before sending the patient, you can expect this patient will take the benefit or not. Okay.
مرحلة قيمة جدا دي وادتنا يعني المدرس دلوقتي مختصم بالترايلز بس عشان في عندنا بالنسبة لنا الترايلز للأطفال. احنا عندنا في حاجتين او في تمبرال فاسكولار اكسس ده عادة بيبقى السيرفيس بالانفورج الموجود في الواحدة هو اوير بيها واوير بالقصة بتاعت الاورجنايزيشن والبروفلاكتيك. لكن احنا عندنا في حاجتين، الحاجة الأولانية بتاعت البرمكاس احنا مبقاش اوير قد ايه دي الديزيز بتاعتي المفروض انا اعمل فيها لوكال اورجنايزيشن الكيت بتاعتي ماشي ازاي مش عارف. الحاجه الثانيه نون ستاندرد كومبيتيشن للفيستولا نفسها زي الفينس هايبر تنشن زي الفيستولا. مين هيتابع الحاجات دي؟ عاده القصه بتاعت الفيستولا وامشن الحاجات دي بتبقى نهايه اذا جابوا ناس فانا المفروض يبقى فيه نوع من انواع يعني الانستراكشنز المفروض الفيستولا دي تبقى فورس او باي الافليتد ميثولوجي او ترجع تاني للسيرجن عمل عمليه بحيث يتابع الفيستولا. هل في
I speak of this before. This is need another presentation about the complication of the system. Dr. Hussein found a time in the schedule, even in the end of the day, we can give presentation about the complication. Okay, because this is, you know, the complication and how to avoid and how to deal with. This will be short, but the most important also from the project we can looking for how the maintenance of the care and the correct surveillance for especially to avoid the main complication, especially the infection and the stenosis and occlusion and so on. I think that with mobilization and the steel, it doesn't take much effort because it is looking for you and looking for patients. You can be referred to the surgeon, he can decide the problem and can deal with. And this need a separate.
انت الاستشفاء على نفسه فعلا تكون مستشفى كده العيان بتخش على الواحد.
It's a teamwork. It's a teamwork, not a nurse alone. So even if it's work of the nurse, the physician must be present and available to give this instruction for the nurse to reach for the patient. So it's a teamwork, not only for one.
Examination of fistula is the responsibility of the urologist, and there is a very nice video on the YouTube which is free and available. Showing how to examine the fistula, how to assess the venous obstruction or the inlet outlets, everything, and it's very nice.
I think I don't read more in the schedule of this program, but you must be available a session about this point, okay? And I will arrange with you another presentation at any time we can to give this session available. And another point of the catheter and the local I speak before about this single job it can be done. Like with injective organization, you can inject the benefit material. You can look, it is written in the pelvic cast, the capacity of the internal lumen for the arterial side and the venous side. This is 20.7 milliliter, this is 1.6 millimeter, so you can drop the amount of the electrotherapy and both equal amounts of this rush of this electrotherapy into the system circulation just only in the lumen, can live for 1 hour and we repeat again and so on. But the very issue, as you finish your work in the catheter, you can also, this is for the closure. The problem in our locality is the allergy developed from repeated use of the streptococcus, and this is problematic, and this is is one of the points which make most of the nephrologists refusing to do more time with this patient because first, tryptophan is expensive also. The vial is 300 Egyptian pounds, only used for 1 day. So if it is another dose after, we need another more. And the problem more not for the money but the allergy. So it's better to have in our that is the leukinase, so every time we can inject this to avoid the closure and the safety to avoid the reaction. Because if you see the reaction from this patient, it is problematic, especially for the young generation.
Also, we have a big hope that we can apply the international standard for selection of surgeons who do fistula. Because there are many publications about the skills of the surgeon who do fistula, and they stated that the surgeon should be observed for at least 25 fistula to be permitted to do it independently.
Really, you are right. Even though in the training program in our units, we try, as you can assume with the senior staff, we can do. But Socrates said that is even in the senior staff, we need the staff which is interested and helpful and have patience to do for this patient. Because if the vascular surgeon comparing between the effort done for this axis and another procedure, who will not do this? Except you feel that you help the patient and give your gift from Allah and not from the patient. This can help to solve this.
I want to leave the fistula for the last of the list of surgery.
Yes, because it's the fistula almost done under local anesthesia, so sometimes the general anesthesia have a time, so you must finish the general procedure first and later on do the some fistula like septic or the transposition it needs intravenous anesthesia, so it's done almost always at the beginning of the...
Even though if this is a facility, we prefer that the surgeon, the senior surgeon,
I agree. Definitely. But you must be looking for another generation, so you must learn. Okay, so you're not only one who can do the fistula, so you must learn more and more.
And so many patients needs superficialization of the vein.
Yes.
What it means and why you are not done at the grave of the patient, not later on.
Now, superficialization means make the vein more superficial, available for the function of the needle, so easy for the nurse or the nephrologist. Some patient who is so the vein, although you are creating the breakage characteristic, you found the vein is lying deep to the part of the nerve more than 2 centimeters. You cannot reach by the needle. And even if you reach one time, the other time it will go and do transfixion, big hematoma, and so on. So in this situation, it's hospitalization. The other items with the basilic vein. Basilic vein starting at the medial aspect of the arm, just above the medial line. But after 1 or 2 centimeters, piercing the deep fascia and become deep. So you can feel the straight here is very well, but the other pathway is deep, not ready for function by the needle. So in this situation, we do hospitalization, which is more common for the basilic vein. Third question, why not to do all at one time? Because hospitalization needs general anesthesia. Very difficult to be done under local anesthesia. Sometimes the cephalic can be done under local anesthesia, but here the basilic vein with the medial venous nerve of the arm and the medial venous of the arm is very good for the patient because the fascia always under local anesthesia. I agree, I did many patients in my young career under local anesthesia, but very frustrated for the patient and for the surgeon. I prefer now to be done under central venous anesthesia, very smooth and be done. The decision to decide, do it like I said before, at one time or not according to the general condition of the patient, and the most important is the diameter of the vein. If the diameter of the vein is good and 4 to 5 millimeters, I advise the patient better do it for one time. Okay? Because it is give the opportunity not to doing a more flat line of communication and what is just subcutaneous and very easy. But sometimes when the patient has borderline vein, you are not sure this vein will work or not by the duplicate scan. So, and the blood pressure is borderline, and you are afraid for him for the long time anesthesia when presenting to you. So at this time, in this situation, I prefer to do under local anesthesia. The first decision for him, everything is okay for him, and for the follow-up, I can give him general anesthesia short time to do hospitalization. So So the decision according to the